Next speaker, thanks, Rowan. Next speaker is John Robertson, and he's going to review the fulvestrant 500 milligrams versus anastrozole as first-line treatment for advanced breast cancer, overall survival from the phase 2 first study.
Thank you, Kent. Thank you for coming today to hear this particular presentation. I want to show you the data, the survival data on the what's called the first study, which is a study of fulvestrant 500, a pure anti-estrogen, versus anastrozole, an aromatase inhibitor, which is the current standard of care in the first-line advanced breast cancer setting. These are my disclosures. I want to put it in context about this drug. This is the background to the first study. Fulvestrant was first developed at a dose of 250 milligrams. And on the left-hand side, you can see fulvestrant 250 versus the current standard again, anastrozole at the time. There were two studies. You'll see study 21, for which actually Kent Osborne was the principal investigator, and study 20, for which one of my colleagues in the UK, Tony Howell, was the principal investigator. That study was set up for superiority, but in fact it showed equivalence. And the reason we could show equivalence was because there were these two studies and you could put them together. You need more patients to show equivalence than superiority as it happens. And so the combination showed that the 250 milligrams was equivalent to the current best treatment, a third-generation aromatase inhibitor. On the right-hand side, the drug was then used against tamoxifen, which was the first-line treatment at that time. We used the word similar in this study because there were not sufficient patients. It was a single study, and there was not enough power to show equivalence. So in the past, with 250, we knew it was equivalent to an AI. It was similar, we said, to tamoxifen as an anti-estrogen. It was then decided that the dose of fulvestrant could be doubled, raised to 500. And this is also a background slide. This is called the CONFIRM study in the second-line setting. Half the patients almost had received an AI, and half the patients had received tamoxifen. And what you can see in this study was that the higher dose of fulvestrant gave an improvement in time to progression. The hazard ratio was 0.8, 20% reduction in progression that was highly significant. And with that came a survival advantage with a nominal p-value of 0.016. I think I have to explain the importance of this in this context. Because when you look back at the aromatase inhibitors, when they became the standard of care for second-line therapy, there was 4 studies against the current standard at that time, which was magistral acetate. There was 2 studies of letrozole versus magistral acetate, and there was 2 studies of anastrozole. None of them showed a benefit in terms of time to progression. It was side effects that made us choose the aromatase inhibitors. So it's quite unusual to see a difference in time to progression and survival in the second-line setting. And so when we saw this, we got excited about it because it's something that we hadn't really seen before in this sort of context. The first study was then looking at the 500 dose in the first-line setting. It's a phase 2 trial, which means it's slightly smaller, as you know, and it's open label. But patients were randomized to either fulvestrant 500 or to anastrozole 1 milligram. And you can see there the follow-up is shown on the slide. The primary endpoint of this study was what we call clinical benefit rate, the number of patients whose disease was controlled at the end of the first 6 months of treatment. And you can see here that there's a numerical advantage in favor of fulvestrant 500, 72.5, versus anastrozole, 67% of women. Hazard ratio is 1.3. In other words, 30% more people had stabilization of their disease. But that was not significant, statistically significant. But it showed that the 2 drugs were equivalent for this primary endpoint. The secondary endpoint was time to progression. And what this showed, and we've previously reported this, was that the new drug, fulvestrant 500, gave significantly longer duration of control of the cancer on treatment. And down the bottom, you can see the median time to progression for anastrozole was 13 months, and for fulvestrant 500 it was almost double that, at 23.4 months. Now, I would just comment that the 13.4 months for the control arm is in keeping with all the previous studies for AI as a first-line treatment. So what we're seeing is an additional control period on the fulvestrant 500. And that was highly significant. You can see the hazard ratio there is 0.66. I'd ask you to keep that in mind for a second. 0.66, a 34% reduction in progression. The survival data that we're going to show you today was not a defined endpoint in the original protocol. It was added following a protocol amendment in February 2011. And it was planned to analyse the data only once when at least 65% of patients had died. And as you can see down the bottom, the analysis occurred when it was 67. So it met its amendment criteria. This is the overall survival analysis. You can see at the top that 23 patients, 22.5% of them, are still alive in fulvestrant, compared to half of that in the anastrozole arm, 10 patients and 9.7%. No patient was unknown or lost to follow-up. There were, however, some patients who didn't participate beyond the original trial in the extended survival follow-up. And you can see down the bottom those two reasons for that. Some individual patients said they didn't want to participate, and some sites said that they no longer wanted to get the additional information. Those patients are included in the survival analysis up to the point of their last follow-up, but not in the extended survival follow-up. All patients are included in the survival analysis. And here is the survival curve. And you can see that the patients who received the fulvestrant 500 dose survived significantly longer than the patients who received the anastrozole 1 milligram. And the hazard ratio is very similar to the TTP at 0.70. 30% less deaths in the patients who received fulvestrant 500 over the study period. And down the bottom you can see the median overall survivals, 48.4% for anastrozole. Again, very much in keeping with previous studies in terms of overall survival for an AI. But for the fulvestrant 500, they had an increased survival of 5.7 months up to 54.1%, and that is significantly different. And to put that in context in terms of the additional benefits we're seeing, when I first started doing treatment of breast cancer 30 years ago, the average survival was 24 months. In this study, we're now at 54 months. We've seen increasing step-by-step improvements, and this is a further step, I believe, in the overall survival benefit that endocrine therapy can bring. The survival benefit appeared to be consistent across all the predefined subgroups, irrespective of age, hormone receptor status, site of disease, prior treatments. So all the various subgroups of patients appeared to benefit. There were no new safety features. These drugs have been given over many years, and the extended follow-up of this study did not show any new safety concerns. So in conclusion, the median overall survival for fulvestrant 500 in this setting is 54.1 months. It is statistically significantly better than anastrozole, the difference being 5.7 months. It was consistent across all the predefined subgroups. No new safety findings. And this is now the second randomized controlled trial where fulvestrant 500 has shown a time to progression and then now a survival advantage over the control arm. I showed you the confirmed data, which was a phase 3 trial in the second line setting, and now the first study, which is a phase 2 trial against anastrozole in the first line setting. I don't know any other endocrine therapy where you can say that we've seen a TTP and a survival benefit in both the second and the first line setting. And so this, I think, is a new and exciting finding for women with endocrine therapy who have got advanced breast cancer. Thank you very much. My acknowledgements.
Thanks, John. As you well know, fulvestrant's had sort of a checkered past. Had to be given intramuscularly once a month. The dose issue that you've pointed out. And then the trial that you showed with tamoxifen showing that it was similar but not better than tamoxifen in first-line therapy sort of stopped the development of fulvestrant in the adjuvant setting. In fact, there were adjuvant trials planned at that time, but because that study was negative, they were not started. In view of the data from CONFIRM and FIRST, do you know of plans to bring fulvestrant back into the adjuvant setting? Many of us, including myself, have thought since development of the drug in the lab that this was the best endocrine therapy that we have, but then we met the problems of dose and so forth. Could you comment on that issue?
Yeah, I mean, you know this drug as well as I do, Kent, and I think that the data on FIRST actually, in some way, cries out for an adjuvant study, because the hazard ratio here of 0.66 for TTP and 0.7 for survival is actually bigger than the hazard ratio that we got between the AIs and tamoxifen. And so one could easily see this moving forward. I think it's now an issue, a commercial issue really, which is that the drug is going to run off patent. And again, as you know, these studies in the adjuvant setting take many years to do. And so I think that what we're going to see is almost certainly that the adjuvant setting will be the next generation of SERDs that will do that. And there are some companies now, including AstraZeneca, who are developing a new pure oral anti-estrogen. We don't know yet if they will be effective, but I think that it's unlikely unless somebody like the NIH takes over and says that they will fund such a study. I think it's unlikely that the company would fund that study, but I think it is crying out to be done given the data we've seen here in the first study.
That concerns me a little bit because after tamoxifen came out, many companies tried to develop a better tamoxifen.
Exactly.
And here we are with tamoxifen 40 years later.
I agree.
So trying to develop a better fulvestrant might work, but I'm skeptical.
I agree, and that's why I said unless somebody like the NIH takes this over and actually, you know, some of the cooperative groups here do this, and I think that the data we have would certainly support that sort of study.
Marisa Weiss, breastcancer.org. Question, since fulvestrant is given by injection by the doctor each time you come in versus Arimidex, the anastrozole by mouth, it could compliance differentiation, like or adherence to the medicine, be part of the explanation for the difference in outcomes, since you know that your patient's taking it because you're the one giving it each month with the fulvestrant, whereas the compliance with the other is not as well known. Yeah. So
it's a good question, and we have no data of measuring hormone levels or estradiol levels in that setting. I'd make two comments. One is that in the advanced setting, I think that compliance becomes less of an issue, but not a non-issue, but less of an issue. So I think patients are more likely to take it. But I think even if that was the case, what it means is if it's for compliance, it still is a better drug to be given. And we saw this before with the aromatase inhibitors. The first generation aromatase inhibitors was a drug called aminoglutathione, which had a terrible side effect profile. And when letrozole came in, there was one study against it, and it's better than the old aminoglutathione, but 9% of patients stopped taking the old drug. And so the question was always, is it better because of being more efficacious, or is it better because more people take it? I think it doesn't really matter in the sense that we're getting better outcomes, but it's a question to be addressed.
Yeah. And I would just add that, I mean, in terms of the adjuvant setting, if the medication could be developed in an oral preparation, then it may be more realistic. But the idea of going in the adjuvant setting for 5 years, going in every month for an injection is just unrealistic, wouldn't you say?
I think it depends the size of the benefit. And I think if you're reducing, you know, mortality by 34%, I think women would take that. And I think we would find ways of delivering it, perhaps in the community. It's not a difficult drug to give. It's an IM injection. You know, community nurses give these injections all the time. So I think if the benefit was high enough, it would be possible to do this. I really don't see an issue with that. When you think back 15 years, doctors and women were, you know, going through high-dose chemotherapy. And in the first studies, 1 in 12 women were dying of the treatment. So I think that, you know, this is a drug that's really well tolerated. It's the way of giving it that may be more complex, but there's ways in which the community nurses could be trained to do that.
Elaine Shatner, Forbes contributor. I'm impressed by the overall survival divergence. I think it's slide number 10.
Yep.
And you pointed to the median survival being different and improved with fulvestrant. For women with advanced disease, as I understand the study,
yes,
that extended divergence of the curves would be very important, as you allude. Is the difference at the end, that is, I think at 8 years, 96 months, is that statistically significant?
Yeah, I think the issue here is it's a phase 2 trial. And so the number of patients at the end becomes small. And so those estimates at the end, even if you were to make them only for the end, become statistically unstable. You have to take the whole period of the curve. And I think that's what we would place the emphasis on. In a bigger study, there is a study that is just ongoing, the phase 3 trial, called the Falcon study. And I think that's got 450 patients. It's actually recruited now, finally stopped in September, and now we await the events. That will give us a better estimate of those later follow-up events. But today we're really focusing on this particular study, which I think shows the pathway forward in the sense that we are seeing now a survival benefit.
And unfortunately, that does have to be our last question because we're out of time.